Hello, hello. Hello, everyone. Thanks a lot for taking time from your busy schedules and joining over here today. Today, we are having a subspecialty VMR of the cardiology and Dr. Tran and Dr. Tran. What's the chance that both of them are not related actually, have graced our occasion with one of them presenting the case and other being kind enough to discuss the case with us. And and also Dr. Jerome and Dr. Seme, who's actually, she just said that it was 4:30 a.m. in her place. And thanks a lot, Seme, for taking time to do this and support us over here. And I am going to be introduced. So Dr. Tran, which is Dr. Philip Tran, and I am associate professor of internal medicine and cardiology at Midwestern University, and he's as well as the dean of Nam Can Tho International Faculty. I'm pronouncing that correctly, Dr. Tran. And he was also the recipient of the Act of Human Kindness Award in 2023, and he was the researcher of the year at ACOI 2023. Welcome, Dr. Tran.
Thank you for a very nice introduction, Dr. Gadi.
Appreciate that. And the other Dr. Tran, who's going to be called as Dr. Nghi from now onwards so that we don't get confused. He's a PGY2 at Weiss Memorial Hospital, and he is also applying for the upcoming cardiology fellowship. And he is graduate from the University of Medicine and Pharmacy, HCMC in Vietnam. Hi, Nghi.
Hi, thank you for having me today.
And then we have Jerome and Sime with the teaching points as well as scribing. And Dr. Philip Tran, can you please tell us what do you like doing outside medicine?
Yeah, so I am living in Prescott, and I like hiking. There's a lot of mountain and lake and outside activity, and I'm a very busy person, but always make time for doing that. Up now, I am a full-time cardiologist at YMC, also a clinical associate professor at Midwestern, also managed the whole medical school in Vietnam at the dean. And I'm also a full-time father for a beautiful 6 years old twin. But then every day, I'll make time either, going swimming with my daughter or take them to the mountain and do hiking. And that's, you will see the life of balance and hard working and life balance always important. And that gives you a lot of energy to do what you want. Thank you.
That's amazing. And they're two daughters, did you say?
Yeah,
Twins?
twin.
Oh,
The twin.
wow. So that's amazing. And
Mhm.
Can you please tell us what do you like doing outside medicine?
Yeah, actually, when I was in medical school, I did a lot of, activities outside medical school. But when I came to the US, because the weather was different, the culture is different. So most of the time, for example, last year when the weather is, hot enough, I usually went out to play volleyball with my friend in the program. And I really enjoy doing that. I feel a little bit more healthy when I do exercise activities.
Awesome. And are you planning to play volleyball anytime this season?
Yes. So I'm waiting, really waiting for the weather to become a little bit warmer, so I can, gather my friend together to play volleyball on the beach. It's beautiful.
Good
Awesome.
luck.
So, whenever is Simi, are you going to be sharing the whiteboard or is Jerome going to be doing it?
Kushal, Jerome is going to share the whiteboard and I'll do the teaching points, but we can, work together and do it as a team.
Perfect. Sounds good. And whenever you're ready, Nghi, can we start our core case?
Sure. So today I'm going to discuss about a case. So this is from a cardiologist standpoint when we get a consultation. So first of all, the reason for consultation is an abnormal EKG with ST 6-month elevation without chest pain on a 20-year-old male.
Sound interesting, huh?
Yeah.
So, Dr. Tran, when you see something like this and you get a consult with an abnormal EKG with an ST elevation and there's no chest pain, what are the things you're thinking of and what are the things you would like as residents or medical students to be aware of?
Sure. So at the elevation in a 20 years old is kind of rare, you know. Usually STEMI is happening in, elderly population is usually more than 40 years old. If you have a 20 years old at the elevation, you have to make sure that, this patient have any other, condition like a coronary abnormality or drug, or inflame, like pericarditis. Yeah. So that's the thing, But also, yes, one of the congenital or Brugada, there's we'll call it subtle at the elevation. That also can taken in consideration.
And I was reading about also ST, reciprocal ST depression, which you would see. And then, so which leads are we thinking about ST elevation, which is significant, and which leads would you be worried or look for depression instead?
Yeah, so let me go ahead and just provide a little bit history and then share the EKG, and then when we see the EKG and we can, discuss further.
Sure.
Sure. So chief complaint of this patient is this patient come because of elevated creatinine level around 10,000. This is a 20-year-old African American male from inpatient psych facility. They brought the hospital because of elevated CK, and the patient was very irritated and have delusional thought, and the patient was unrestrained in the nursing home. And when the patient was brought to our hospital, the patient denies any chest pain, shortness of breath, and palpitation. In the ED, they do supportive management with IV fluid. And of course, the patient is still having 4-point restraint just to make sure that the patient calm down. And the patient later on, the patient will transfer to ICU just for observation. But here in the ED, when they do the, if the first EKG, it look like this. I'm gonna share my screen here. Are you able to see the EKG?
Yes, we can see.
So this is the EKG on admission. And Dr. Philip Tran, may you discuss a little bit about what you can see in the EKG?
I would like to ask the medical resident or the attendant first. What do you
Okay.
see? What is the abnormality in this EKG? Very interesting. Yeah.
Yeah.
Anyone can tell us,
Yeah, so what I can see from this EKG is at first I saw this patient is a little bit tachycardic. The heart rate around 150, and then the patient first of all, when I saw a lot of ST 6-month abnormality, and more prominently I can see it in the V4, V5, V6 with ST 6-month elevation, and on top of that I can saw some PR depression in D1, D2, and D3 as well. I saw some T-wave inversion in AVIA, and yeah, and that's pretty much what I can see. QTC is okay, and this with this EKG, I really concerned for what really going on very young men.
Yeah. So you're right. I can see here this few at the elevation actually. The AVR doesn't count because it's on the right, you know. So all the leads you say more or less at the elevation, this few at the elevation, and the pattern. Look at the pattern of the at the elevation. Anyone tell me if that's what do you have in mind with this EKG? Anyone can contribute, you know, because this is a discussion. So yeah, so like Manzu, he say what pericarditis and what else, you know. So from this EKG, right, you see that it's almost like this few at the elevation, and is either concavity or convexity. The pattern of the at the elevation. So it's concavity, okay? Meaning it going up and then it's going down and then up, okay? Concavity, yes. Thank you, Himun, okay? And then what else you can see? You can see that PR depression, right? And PR depression, especially in D1 and D2 and maybe AVL, okay? So with this EKG, what do you have in mind? So number one, you know, still you have to think, even though 20 years old, you have to think if that is STEMI, okay? Because STEMI time it is, if you miss the other, it's fine, but you know, you have time. If you miss STEMI, it's not gonna be good, okay? And STEMI can happen in 20 years old, okay? So number one is STEMI, but what kind of STEMI in here, okay? So we don't have when we're talking STEMI, we're talking about the local, okay, of the vessel, like, you know, V1 to V3 or V4, 5, V5, 6, AVL is lateral, or 2, 3, AVF is the inferior, okay. But this one kind of diffuse. When you have at the elevation diffusely, you know, what do you have in mind? What kind of STEMI? It could be triple vessel or what? Or left main disease. Okay. So that's the number one STEMI. You have to rule out, number one, you have to rule out if that's STEMI. Okay. And number two, what else that you can have at the elevation? Pericarditis, of course, you know, pericarditis. And what else? Pericarditis, thank you, Epi. Yeah. Pericarditis, or you can have a secondary chain, but secondary chain we're talking later, you know, not in this pattern, okay? The good thing in here is you have a concavity, okay? Concavity at the elevation. So, of course, you know, your first impression is still acute pericarditis, but the thing you need to rule out is STEMI, okay? Thank you. You can move forward. And always looking for the O EKG, okay? You have an O EKG in here?
Yes, we do.
Okay, show us, please.
So this is the EKG done in 2024.
It's absolutely changed, right?
Yeah.
So it absolutely changed. So something going on, okay? You can move on.
Okay. So we admit the patient to the hospital. Let me stop the sharing. Okay. So we go over the past medical history. This patient has schizophrenia since 16 years old, and the patient also have the history of PTSD secondary to child abuse before. The patient currently taking medication including risperidone, olanzapine, thioradazine, and Benadryl. All of these 4 medication is for his psych. Vital on admission is pretty much stable, temperature 36.4 Celsius degree, heart rate 121, a little bit tachycardic. Blood pressure is 145/71, and respiratory rate 16. Physical examination pretty much benign, but notable for the patient have a lot of involuntary hand and face movement. When we listen to the lung, is no crackles. We listen to the heart, a little bit tachycardic, but no murmur and no ultrasound like friction rub. Abdominal is non-tender, non-distended. Muscular skeletal, the patient is very muscular man, and neurological pretty much benign. Regarding the psychiatric, the patient is very irritated / agitated. The patient have some bizarre thought and zoom in on multiple topics, but no hallucination and no suicidal thoughts. So because this patient require 4-point restraint, so we need to admit to the ICU as a protocol in our hospital. And we also have some labs for the patient. So these are the initial labs, WBC 9.8, hemoglobin 11.6, platelet 258. CMP show electrolytes within normal limit, liver function test within normal limit, creatinine 0.99 with BUN 44, GFR more than 60. And then the patient will repeat a CK level when the patient admitted to our hospital. CK level is 9,588. And then we also have the first troponin for this patient, 0.02, which were negative. We also do the urine drug test, and it was negative. And urinalysis was unremarkable as well. We did the chest X-ray. It showed no acute pulmonology pathology. Okay. And then we admit the patient to the ICU. We continue to give the patient IV fluid regarding the rhabdomyolysis. We was thinking it might be come from the patient got agitated and the patient restrained, so his muscle breaking down, causing rhabdomyolysis and elevated CK. And then we also train the troponin 3 times. And let me show you the EKG after 10 hours after the admission.
Dr. Nate, did you want to share it
again? Yeah. So this is the EKG 10 hours after admission.
Dr. Tran, to summarize the case so far for everyone who has just joined, so I'm just going to summarize it. So there was a 20-year-old male who came in from the inpatient psych facility because he was agitated and had a history of delusion. And he was on risperidone and Benadryl, and his CK was elevated at 10,000 units, and that's why he was brought to the hospital. And his temperature, his BP was 145/71. His temperature was 36.4. Heart rate was at 125, which is tachycardic. Since he required a 4-point restraints, he was admitted in the ICU, where Dr. Nghi had actually seen him. And the patient's initial creatinine was at 0.99 and BUN was at 44 and CK was again at 10,000. TROP was negative at 0.02. And it says initial ECG on admission had an ST elevation and the patient had no complaints of chest pain. And now what he's showing is the ECG at 10 hours after post-admission. And did you want to have a final read for this, or did you want to give a couple of minutes for the audience to give what that read was before you revealed the read? Ni?
Yes, let me go over. I think this is at this time totally this is the abnormal EKG. So first thing first, I saw that the patient still have ST segment elevation in V4, V5, V6, which is a little bit similar to the previous one. But now we also have the ST segment elevation on more significant on D1 and D2 as well. On top of that, some PR depression in D1, D2 as well. And as Dr. Philip Tran says, we need to make sure this is not coronary related disease like STEMI or so. So at this time, at this point of time, I admitted the patient, and I'm gonna train the troponin, at least 3 samples of troponin, and also train the EKG as well, and make sure that I'm gonna get the cardiology on board. So when the cardiologist, I took the picture and I sent to the cardiologist. So he's a little bit thinking about, should we get the echocardiogram on this patient? Should it be the benign early repolarization, or should it be a real MI case, or it should be an acute pericarditis? To differentiate between these 3 things, I might need the experts from Dr. Philip Tran.
Sure. So let's summarize. Okay, so we have a 20 years old and who have history of schizophrenia, who admitted for shortness of breath, and have the prominent is he have abnormal EKG, and he have an elevator of CPK of 9,000. Right? This is what abnormal so far, right? So what do you have in mind? What do you
So
have in
first,
mind?
yeah, first thing first. So for CK, so I thought it come from rhabdomyolysis, from the patient was agitated and on restraint, especially have 4-point restraint, and the patient is very muscular, I would say. So I think the CK elevated come from the muscle breakdown on this patient. But also I also keep in mind that maybe an QMI also produce some CK. So I sent the profile of CKMP as well. And the lab come back, the ratio of CKMP per CK is 0%. So at this point of time, I think it's most related with the rhabdomyolysis.
Okay, so rhabdomyolysis etiology for this patient, right? So it could be from strain, but the strain is usually not really, rough to make it like rhabdomyolysis here. He on antipsychotics. He's on any medication for antipsychotics. Though medication can cause rhabdo in my, I saw it's very common. Thing is like, haloperidol, yeah. So it can cause rhabdomyolysis and some SSRI, especially in patient with psychotic, So make sure that you also discontinue those medication for temporarily, and see how it is. Okay. And then the other thing is malignant hyperthermic risk. I think this it could be, but in this patient, there is we just follow. There is no evidence of that first. Okay, and so that's for the CPK, and the other one is could be from the harm muscle, right? But the troponin and the ratio is 0, so it's less likely. Okay. Again, with this EKG, the very first thing you have to do is rule out if that's STEMI. Okay, before you can come to clue that is acute pericarditis. Okay, so a couple of things for you to do more further investigation to rule out the STEMI. Okay, number one is that family history of any QMI or cardiac arrest, because there's some form of family history is also contribute. I saw a person who have a STEMI at their in 60 years old. So that's number one. Okay, and number two, does this patient have any risk factor for coronary disease? And definitely, we don't have, right, Dr. Ni? So we don't have
Yeah.
hypertension, cholesterol, or diabetes, or smoking, or anything like that, right? So, and then next, you will ask the patient if they have any chest pain or anything. The chest pain, is one of the criteria for, for MI, but the pain perception is different from person to person. So you cannot rely on that, okay? And next thing is if the patient into any drug, cocaine or anything like that, you have to do a urine drug screening to rule out that. Okay, and usually the drug abuse they is not reliable from the patient. You have to prove that. Okay, and one more, another thing is coronary anomaly. Okay, like thing like left main come from the the right and wrap around the heart, and when the patient have contusion or something, it might injure and is make it STEMI. Those kind of things you have to be cautious and rule out when you first see the patient with this kind of EKG. And then when you rule out everything, troponin negative, and they know then no negative for all the thing that I just tell you, then you will can conclude, oh, it could be pericardial effusion, carditis, and because to prove that, you will do the cardiac study. And one of the things that you can do right away is what? A bedside echocardiogram. Looking for what? Reasonable wall motion abnormality. Okay? Yeah, you can do that right away. The test will come right away, and then you do that, or they have it in the ER. You can do that, and you see that LV function is fine. Let's see this patient come in and they say, wow, this one you have what? You have ejection fraction only 20%. And you have fluids around your heart. Then you can think a different way. Okay, so for this patient, unfortunately, they don't do echocardiogram, but that you should do. Okay, and after you have that and you rule out everything, then you say, well, this could be acute pericarditis. Okay, and then you prove this is, if this is pericarditis by what? Number one, if the patient have fever or not, if the patient have pericardial rough on the examination, or if the patient have any change in the EKG or chest pain. If you miss two of that four criteria, you can diagnose of acute pericarditis for clinically. Okay, and then the next step is, should this patient admit for to treat for acute pericarditis? Remember, majority of acute pericarditis, you don't need to admit the patient. So, Dr. Ni, can you tell me in what situation, or anyone here, in what situation an acute pericarditis need to be admitted?
I'm gonna try first. So,
Yes.
I think for only acute pericarditis need to be admitted to the hospital. I think the patient have chest pain that's kind of unbearable chest pain, severe chest pain. And that is my thought for
Mhm.
now. So anyone else can help me? Oh, somebody,
Rao,
Rao, yeah.
the Rao put in the good point. That is lot pericardial diffusion or tamonate. That the
Mm.
emergency that you need to admit the patient and
Mm.
and do pericardial type. Okay, that number one. Number two, if the patient have a high fever, okay, because the high fever it could indicate for etiology, could be TB, or it could be pus, or that need to admit for antibiotic. Okay, and number 3, if it is subacute onset, why is that? Is subacute onset of pericarditis. That pericarditis is hard to treat with a common regime like colchicine or NSAID, and that need to be more investigation. Okay, and if the patient on anticoagulation, and why is that?
I think it's gonna be easily to convert to hemorrhage, pericardial
Yes,
hemorrhage.
bleeding. Yes, bleeding. Or if the patient have, pericarditis after trauma. Okay, so that is the criteria for admission on pericarditis. Okay. Menzu say pericarditis high risk. Yes, and so this patient clearly, pericarditis, right? Even though he doesn't have a echocardiogram, but he present with no chest pain. Okay, no chest pain, and the only thing he changed in the EKG, she doesn't have a history of any congenital or family history. Doesn't have a history of cocaine or drug. Drug is already negative, right?
Yeah, urine
Yes.
drug urine was
Yeah.
negative.
So likely is acute pericarditis. Now, pericarditis, what is the etiology?
So it depends on the country. So if the patient in a developed country within the like in the US, most of the causes is gonna be viral causes. The second more common may be due to some autoimmune etiology like rheumatoid. But in developing country, the acute pericarditis is gonna come from TP. And also we need to think about malignancy and other things as well.
Excellent. And another thing is after MI, after STEMI, after angioplasty, after CABG, we also have it. But one of the things that I want you is also idiopathic. We see a lot of idiopathic. So like this patient, it could be because he doesn't have any viral syndrome or anything before, right? No fever or anything. So idiopathy meaning we don't know why. So that could be another etiology. Okay. And how do you diagnose of acute pericarditis?
So from my understanding, so the patient need to meet at least 2 out of 4 the criteria to be diagnosed as the acute pericarditis. First is typical chest pain. Second is examination. We hear some pericardial friction rub. Third thing, we have the EKG, which suggests acute pericarditis. And the last one is the new or worsening pericardial effusion on echocardiogram.
Excellent. Excellent. If you have a 2 and above, then that is a clinical diagnosis of acute pericarditis. Okay. And we already talked about hospitalization criteria, right? Fever more than 38, subacute onset, large pericardial effusion or tamponade, if the patient on anticoagulation or trauma, right? So if that's okay to move on treatment, yes?
Yeah, sure.
I'm just going to interrupt just tiny bit over here, Ni, if you don't mind. Dr. Philip Tran, there was one question in the chat where one of them was asking, what's the pathophysiology of gaining an ST segment elevation and a pericarditis? If you didn't mind, could you
inflame? That's just inflame, So inflame in the myocardium, it will change in the repolarization. Remember, it's FT is represent for repolarization. It slow down and it will cause change in the FT elevation. The same thing, ischemia the same, and inflame the same. It slow down the electricity activity there, and especially in the repolarization, and it's called VAS. Okay.
Amazing discussion so far. Thanks a lot, Dr. Philip Tran. Ni, you can take the floor.
Sure. So let me summarize a little bit about hospital costs on this patient. So when we admit the patient into the ICU, we also send some set rate and CRP, which is elevated. CRP 5.28 and set rate on day 2 is 40. On day 3 go up to 60, and on day 4 go up to 84. We repeated 3 times of troponin, which were negative. We tried to do the echocardiogram, but it's not be done because the patient is very agitated. Even though we put the patient on maximum dose of Persedex, which is the strong alpha agonist to calm down the patient, but the patient is still very agitated. So we could not to do the echocardiogram on him. We consulted cardiology and cardiology before day 4. Cardiology still want to see the echocardiogram result because this patient only meet 1 out of 4 the criteria for the acute pericarditis, which is the patient have abnormal EKG. So moving on the few days after that, CK level started trending down after IV fluid. It go down to 7,000, go down to 5,000 the next day, go to 3,000 on day 4, and 2,900 on the day of being discharged. So the next thing is there's some discussion about the treatment of acute pericarditis. Because we was not able to obtain the echocardiogram on this patient, so we have a very long discussion with the cardiologist team to see should we start treatment on this patient or not. So I would give some thought about that for Dr. Philip Tran.
Yes, good question. Yes. So we already done with the diagnosis. We already done with the criteria for admission, and now we have confirmed this patient have a acute pericarditis. And the next move is should we treat this patient? Remember, majority of the pericarditis they cell limited because they are like viral infection. You know, we treat when the patient have symptom, and the symptom is chest pain. This patient absolutely don't have a chest pain. You know, so you can treat to for the EKG and things like that. But this patient, my feeling is the patient will resolve in the matter of 3 to 7 day. EKG will improve back to normal. You know, and for me, you know, I don't treat pericarditis like a first hand right away. Okay, it depends on the marker, it depends on the symptom, it depends on the represent in the EKG. For this patient, she already have evidence of inflamed by the ESR increase, right? So this one, you can base on treatment. And the treatment, standard treatment for this patient is to start with the NSAID 2 to 4 weeks with high dose. You know, usually we do ibuprofen 800 TID, with the colchicine for 3 months. Okay, so the NSAID actually is treat the symptom and the chest pain. The colchicine is actually prevent the recurrence because the rate for recurrent pericarditis is about 15 to 30%. Okay, so for this patient, yes, it's a treat. I totally agree with Dr. Ni. Okay, so the patient need to be treated on NSAID high dose and colchicine 3 months. 3 months. Okay, to prevent the recurrent. Okay, so that's number one. Now let's see this patient. I mean, this patient is a simple case, you know, because they don't have a chest pain, they don't have elevated troponin. Okay, but let's see if the patient, you know, come with chest pain. Okay, come with elevated troponin. Okay, what do you think in mind? It could be peri-endocarditis. Okay, so inflame of the sac is also inflame of the muscle. Okay, for that, you know, the treatment is it could be longer. Okay, and the treatment the same, but it could be longer. Okay, and you have to tell the patient that the patient not participate in competitive sport, you know, for 3 months. That's the only difference. Okay, because the muscle can be ruptured, you know, in the first 3 months. Otherwise, treatment the same. Okay. Then okay, for this patient it's easy, but I make it complex. Okay, you treat for 3 months. Okay, and for the first, you know, week or two, patient everything come back to normal. Okay, and everything fine. So you do 3 months of coaching. That's right. But then 6 months later on, when she come back, she have a shortness of breath and she have chest pain. And you do echo and you see, whoop, that pericarditis again, you know, pericardial effusion again, and pericarditis again, you know. So what do you do, Dr. Nee?
So I think that
What do you
we
do?
can, yes, we can escalate the treatment for recurrent pericarditis. We can add prednisone, steroid on this patient on top of the consisting. That is I think that's a second line treatment. And also recently come out, there's a few interleukin inhibitor pathway, which inhibitor the interleukin pathway. This medication gonna be helpful with recurrent acute pericarditis like rilonacept or anakinra.
What you concerned about the steroid?
So the steroids, because as we discussed earlier, this is might be viral things, and as if we remember, there's a criteria for admission of acute pericarditis that the patient was on immunodepression medication, and also one of the things for pericarditis might be from the infection as well. So if we give the patient prednisone, especially the dose of prednisone, that can lower the immune system. So this is my thought.
So the answer is a good guess. Okay. Never think about steroid first. Okay. And I'll tell you when the steroid should be used. Okay. If a second, I mean, the first is already right now. Second pericarditis, you still use the same. Okay. And don't think about the steroid. Yes. Okay. Because the concern for steroid is the relapse is high. If you already use the steroid, then the relapse or the recurrent, the third time and the end time, the 10th time, it's more, you know. So don't think about the steroid first. Okay. Thinking about the first regimen is still 2 weeks of NSAID, and now a 6 month of coaching. Okay, a 6 month of coaching for the second recurrent pericarditis. Okay, now when did you start thinking of the steroid? Okay, the steroid would indicate if the patient have a comorbidity. Okay, like if the patient have a autoimmunity, if the patient have a um, if the patient have a on anticoagulation already, you know, because you know you use the high dose of NSAID, the patient can bleeding profusely. Okay, so if the patient already on anticoagulation, or if the patient have a renal failure, you know, 'cause you have kidney, you know, failure, you don't want to give high dose of NSAID. It can the kidney can be getting worse. Okay, and so that is the indication for steroid. Steroid is second line, and it have high rates of relapse or recurrent. Okay, now for that patient, if they come with third time and now after 6 months, after a year, you on that regimen, and the patient come in and have significant chest pain with pericarditis and pleural effusion, cardiac effusion, then you have to think of the clinical trial. If you do third time, then you have to do steroid. Okay. And now you do steroid, it's quick, it's helpful with the chest pain and everything. Okay. And but the patient will come back. I'm telling you, you know. And if you fail the steroid, there's a new medication. It called interleukin 1 inhibitor. The thing is what we call like anakira. Okay, or you can do azathioprine. That two medication that's more used in term of complex pericarditis. Okay, but that's one it will decided by cardiologists. Okay, at a internal medicine doctor, I will say take what the first regimen. Okay, SS and coaching 3 months for prevention if the first, and 6 months for prevention for the second, and you'll be good. If it's third time, okay, give it to Dr. Phil. Okay, and I'll make decision. Okay, and the anakira and the azathioprine we use this in a rare case, in the complex uh, cases. All right, so for this patient, thing is very straightforward. You know, no chest pain, and no elevated troponin. Thing is make it so much easy. But you see this EKG, and you see a patient have elevated troponin, then many things can be thing off your mind. Okay, is that STEMI? Is that Takotsubo? And in the young people, you know, is that you know so many things there. Okay, and the treatment we already talked about. We simple and complex case. Okay.
Yeah. Dr. Tran, I have one
Yes.
question for you.
Yes.
So, how important is it to identify the cause of the pericarditis? Or is it
Uh,
something which we have to do at all? Like, do we have to do the influenza swab? Or do we have to do what the cause of it is?
the call. Excellent question. You know, in terms of pericarditis, for my personal expertise experience, um, you know, you had to rule out if it is infection. That's it. You know, the other viral or idiopathy is, you know, you're not going to treat that. Okay, but if you don't want to miss a TB, a patient coming from Vietnam, come from Laos, come in have fever, come in it's fever at you know at nighttime sweating and now have this chest pain, you know, then you have to think about etiology in order to treat, or the patient yeah, you know, immunocompromised and HIV come in and have a fever, you have to think if that pus is abscess, you know. So those kind of thing is you know, you have to find out. Otherwise, you know, autoimmune disease patient already had that, you know, they come in and they, oh, it could be autoimmune disease, you know. Otherwise, viral and idiopathy, you don't treat the etiology, right? Yeah. So that's
Thanks a
how.
lot. Thank you so much for
Yeah.
those teaching pearls. Dr. Tran, we are going to be running short of time very soon. Not yet, though. But before we do, I was wondering if you could give us 3 important teaching pearls which you would like us to take from this whole
Sure.
session.
Thank you. 3 things I want to do. Okay, number one, when you have a patient come in with before diagnosis of acute pericarditis, you have to leave. You have to rule out if it's STEMI. Very important. Even though you know it's 20 years old and chest pain free, it is a very important. If you miss a STEMI, it's not gonna be fun. Okay, so number one. Okay, and in order to do that, you have to looking forward. You know, family history, risk factor for coronary disease, and diagnosis of STEMI is what, you know, EKG and things like that. Okay, second one is the treatment. Always stick at the primary care doctor. Always stick with 2 weeks of NSAID to, you know, for chest pain, and 3 month for prevention with coaching. And that is happening again, do a 6 month of coaching. Okay, and hold hold on the steroid, okay? And the next thing is always looking for complication, and advise the patient. A lot of patients come with chest pain and also have associated with peri-endocarditis. You had to prevent, avoid competitive athletic activity, okay? Because it could have, because the majority of the young, okay? That's it.
Awesome. And Nee, did you have any teaching points, or what did you learn while taking care of this patient?
Yes, actually, I learned a lot about acute pericarditis on this patient. I was a little bit freaked out when I see the ST segment elevation like this, even though it's like in the textbook, but it's very concerning when you are in the ICU. And it helped me a lot about how we can manage the acute pericarditis and what should we do with this. And I can clearly see the change in the EKG in reality, which is very good. And from now on, I'm going to remember every single detail of pericarditis EKG and other stuff as well. So, and I also learned a little bit about maybe something kind of, early repolarization on the EKG that's sometimes mimicking on this EKG, but that's going to be a little bit different compared to acute pericarditis on this patient. So if any of you have time, you can read more about that. And that's pretty much.
Thanks a lot, Nee. And since we are going to be running out of time soon, Sime, did you want to share one thing you learned, just one thing which you learned from this whole 1 hour session?
I think, Kushal, it was such a great session, and I got to learn so much from Dr. Philip and from you and everyone here. And it is very difficult for me to decide on one thing, but I think the treatment that was mentioned, that the first line we need to give NSAIDs for 2 to 4 weeks and colchicine for 3 months. And if the patient has recurrence, we do not use steroids, we use colchicine this time for 6 months. And steroids can be used only in patients who are either on anticoagulants or have renal failure. And that if steroids fail, then we come to interleukin-1 inhibitors. So this is what I would love to share, but I think each point was just so great, and I had great learning. So thank you so much for sharing the case with us, and also Dr. Tran for the amazing discussion, and Kushal for facilitating, and love the thoughts in the chat.
Yeah. Thanks a lot, everyone, for joining, and see you all soon.
Thank you.
Thank you.
Thank you. Bye-bye.
Bye.